coordinator for the Western Cape. I'm going to do the notifiable medical conditions case definition and clinical procedure training for Category 2 NMC. Your outline will be the list of Category 2 NMCs and then NMC Category 2 case definitions. That is the list for the Category 2 notifiable medical conditions. We will start off with agricultural or stock remedy poisoning. So chemical substance or mixture of a substance intended to kill, repel, or control forms of plant or animal life considered to be pests or to regulate plant growth. It's also a herbicide, insecticide, fungicide, rodenticide, and repellents. Toxicity dependent on function, formulation, and the route of exposure. It's classified as occupational and non-occupational. Who should notify? It's any healthcare provider making the clinical diagnosis for a suspected, probable, or confirmed case. Clinicians should not wait for any lab report to confirm before notifying. Pesticide poisoning, that's part of your agricultural and stock remedies. Remember, all of your poisons fall under that heading. Routes of exposure. There are various routes of human exposure to pesticides. These can be characterized as ingestion, accidental or intentional inhalation, breathing in fumes or particulate matter without correct use of PPE. There can also be skin contact, spillage of your solvent or solid onto skin without correct use of the PPE. Routes of exposure, so if ingestion, it could be by mouth, then it goes to the GI tract and out with the feces. A person can also inhale it through the mouth or the nose, and it will go to the lungs, the liver, the kidneys, and then into the urine. With skin absorption, it can go to your blood stream and lymph nodes, also to your fats, your sweat, and mammary glands. Also in milk with breastfeeding, lactating women, in the tears and saliva. Mercury poisoning, that is inhalation especially, toxicity of mercury and the treatment. So with toxicity, elemental mercury and methyl mercury, toxic to the central and peripheral nervous system. Inhalation of mercury vapor affects your nervous system, digestive and immune systems, lungs, and the kidneys. Neurological and behavioral disorders may occur after the inhalation or ingestion, or if there's dermal exposure. The patient may have tremors, insomnia, memory loss, neuromuscular effects, headaches, and cognitive and motor dysfunction. Children and pregnant women, there may be transplacental exposure, which the fetus may be sensitive to, and it will affect the brain. With chronic exposure, neurological symptoms may also affect the intellectual ability of the child. There may be seizures, vision and hearing loss, delayed development, language disorders, and memory loss. Acrodynia, so that's Pink's disease, also known as, and that's when the hands and the feet become pink. Treatment, prevent further exposure, move to a mercury-free environment, supportive care, chelation, so that will be the DMPS is preferred, the preferred oral agent, also available via intramuscular or intravenous. Alternative oral agent will be the DMSA, Succimer, and then dimercaprol, parenteral if renal impairment is involved. So with the chelation, you will see how long it takes for the mercury or any other solid metal to leave the body. So this is an example of a patient who has had a very high level of 260 millimeters per liter. From August month up until October month, it took that long to actually bring the level to close to a normal level in the blood. It can also be in urine samples that it can be tested for. Lead poisoning. These are usually in your ingestion and inhalation with lead dust from industrial sources, toxicity of your lead and treatment, toxicity, complex biomolecular effects, interferes with the cellular metabolism in heme synthesis, cellular oxidative stress, calcium and zinc metabolic pathways. Your multisystem toxicity is that neurology, hematologic, nephrocardio, reproductive, endocrine, skeletal, and GIT systems may be affected, and the toxicity may be in any one of those systems. Treatment, prevent further exposure, environmental intervention is necessary, foreign body removal as soon as possible, to an X-ray, also endoscopy, any kind of surgery, correct your iron deficiency, supportive care, encephalopathy, renal and hepatic functions need to be checked, and then they do also chelation of the calcium EDTA via IV for encephalopathy, or they will administer Sacumer DMSA orally. Your case definition, one of two, clinical case definition of a suspected pesticide exposure case. Your pesticide exposure, report of acute pesticide exposure from a patient or a witness in normally your emergency unit. Probable case definition, if a criterion as for a suspected case must have a health effect, criterion as for confirmed case, or if criterion as for a confirmed case may have health effects, criterion as for suspected case. A confirmed case, so observation of residue to note any odor or clinical response to treatment, or an antidote, for example, atropine, or clinical description by a healthcare provider of equal to or more than 2 post-exposure health effects, at least one of which is a sign characteristic for that pesticide, or there's a laboratory confirmed test demonstrating physiological response to the pesticide. For example, if there's prolonged clotting or pseudocholinesterase levels are below the normal lab range levels. A case definition, number 2, your health effects, your healthcare provider is documenting more or equal to 2 new post-exposure symptoms. A probable case, if criterion as for a suspected case, must have a pesticide exposure criterion as for confirmed case, or if a criterion as for a confirmed case may have a pesticide exposure criterion as for a suspected case. Your confirmed case definition, your healthcare provider who's documenting equal to or more than 2 characteristic signs, or a healthcare provider documenting equal to or more than 3 new post-exposure characteristic symptoms or notifiable medical conditions. Case definition flip chart, case definition flip chart on page 31. You can have a look, and if you read that it occurs within a reasonable time period after exposure, autopsy evidence of the pesticide poisoning will show, and that will be indicative of a confirmed case. The cause-effect relationship, so the healthcare worker must not be associated with any other, the health effects must not be associated with any other likely explanation and occur within a reasonable time frame after the exposure to that pesticide. The health effect must be characteristic of that pesticide and occur within a reasonable time period after exposure. The health effect must be characteristic of that pesticide and occur within a reasonable time period after exposure. For mercury, your case definition, so mercury concentrations, urine, which is in a urine sample, if the test result shows that it's more than or equal to 10 micro millimeters per liter, or in a blood sample more than or equal to 10 micromillimeters per liter. Your disease epidemiology. So mercury is an element that occurs widely in the environment from both natural and human sources. It may come from mining waste, especially informal gold mining, municipal incinerators, power plants, hazardous waste sites, dentistry, medical equipment, and manufacture of products containing mercury. Mercury occurs in three forms: organic, inorganic, or elemental. All forms of mercury, and especially the organic form, are toxic. So the clinical presentation varies depending upon the form of that mercury exposure, as well as the route of that exposure. All organ systems can be affected, and effects may be acute or chronic. Organic mercury, that's ingestion, most common route, followed by inhalation and dermal exposures. Toxicity can be delayed for weeks and usually involves the central nervous system with paresthesia, headaches, ataxia, dysarthria, visual field constriction, blindness, and hearing impairment. Inorganic mercury ingestion, most common route of toxicity: acute toxicity, gastrointestinal symptoms, shock, renal failure, and death. Chronic toxicity, neurological, dermatological, and renal manifestations, including neuropsychiatric disturbances with memory loss, irritability, gingivostomatitis, discoloration or disquamation of your hands and feet, and also hypertension may occur. Elemental mercury inhalation, most typical route of toxicity: acute toxicity, fever, fatigue, as well as GIT symptoms, respiratory again, and central nervous system effects. Your chronic toxicity is similar to inorganic toxicity. So a clinical case definition for a suspected case is a potentially mercury exposed case being evaluated by a healthcare worker or public health official for mercury poisoning. Probable case definition: a clinical compatible case with a high index of suspicion for mercury exposure due to the case's history regarding location, source, and time of exposure, or a clinically compatible case with an epidemiological link to a case with a laboratory evidence. A confirmed case will be a clinical case compatible in a person with a history of exposure and your lab evidence. So that will be organic mercury of equal to and more than 10 microliters in a liter in whole blood, or inorganic mercury levels of more than or equal to 10 microliters in a liter in 24-hour urine or in whole blood. Elemental mercury, the same level in a 24-hour urine or in whole blood, and that will be the first few days after exposure only. Lead cases, the case definition. So your concentration will be, the blood sample will show more than or equal to 5 microliters per deciliter. Lead is naturally occurring silver gray metal with properties such as malleability and low melting point and non-corrosive. Due to its versatility, lead is used in many circumstances and products, including batteries, petrol, paint, pigments, firearms, ammunition, artisanal cookware, ceramic ware, traditional medicines, protective equipment, cabling, and certain cottage industries. Soil and dust can also be contaminated with lead particles. So exposure is mainly by ingestion or inhalation with lead being stored in the body for many years. Lead may cause acute toxicity, but more commonly subclinical lead exposure leads to chronic toxicity. The target organs of lead toxicity are central and the peripheral nervous systems, the kidneys, and the gastrointestinal system. Lead may also produce hematological effects in children undergoing investigation for anemia, recurrent abdominal pain, and pica. Blood lead concentration should be measured. A clinical case definition of a suspected case, so it's a potentially lead exposed case being evaluated by a healthcare worker or a public health official. A case with a single capillary blood specimen with lead levels of 5 microliters per deciliter. Proper case definition is a clinical compatible case with a high index of suspicion for lead exposure due to a case's history regarding location, source, and time of exposure, or A clinically compatible case with an epidemiological link to a case with a lab evidence, or a case with 2 capillary blood specimens drawn within 12 weeks, both with the levels more than 5 microliters per deciliter. Your confirmed case is children and your adults with either of the following. So a blood level of more than 5 in whole blood from a venous specimen, or a blood level of more than 5 measured from 2 capillary specimens taken within a period of 4 weeks. Roles and responsibilities are vital to the prevention, detection, diagnosis, and the treatment of pesticide poisoning. And we have tabulated below the roles and responsibilities of all the key stakeholders from national, province, district, sub-district, and your health facility level. So from a national level, the responsible EHP coordinator, the roles and responsibilities point the person and National Department of Health will share an annual basis, the number of cases reported per province and what interventions were implemented to prevent its reoccurrence. In the province, the provincial CDC coordinator, provincial NMC surveillance manager, provincial epidemiologist. So your provincial CDC office facilitates your NMC forms and your case investigation forms to the next focal level. If electronic data capture is not possible from a facility level, then the provincial NMC focal person must send the form to the NMC surveillance report at nicd.ac.za. Following receipt of a lab completed NMC case, your notification form, ensure the form is captured clinically onto the NMC reporting app. Provide epidemiological, operational, and investigational feedback reports on chemical poisoning cases, line list, environmental health reports, and case investigation forms to the provincial, district, as well as to the health establishment levels. From a province, district, and sub-district level, your EHP should ensure that the registration and training on the NMC platform will allow for all to access the specific NMC conditions, like, for example, the organophosphate, mercury, and lead poisoning of the exposed cases. They have to also draw a line list of chemical poisoning cases reported by facilities and to search that NMC reporting app for the form for that particular patient, conduct environmental assessments and investigations as stated in the national guideline for the investigation and environmental control of human chemical exposure and poisoning cases. Complete also a specific case investigation form and accompany that with a rapid report to provide comprehensive information to your provincial office, district office, as well as sub-district office. Submit these forms to the appropriate offices of focal persons for verification. All the environmental health and key intervention documentation will be then submitted to the provincial EHP manager from the sub-district offices and facility offices. Provincial and district municipality environmental health units are responsible to ensure that the investigation forms are completed and submitted to the national level and focal persons in the National Department of Health. Review the completed case investigation form and provide feedback to the facility who has treated that patient. So that will be also your IPC practitioner, general practitioner, maybe from a private practice, and your CDC manager at the district as well as the provincial level. Your roles and responsibilities from district, sub-districts, offices or substructures. The responsible personnel will be your CDC focal coordinators, so that will be officials responsible for CDC, IPC, surveillance, information management, epidemiologists, and, for example, facility-based programs. The roles and responsibilities are that they have to ensure registration and training on the NMC reporting app and obtain access to draw line lists and NMC forms for the chemical poisoning cases, and ensure that they coordinate the training of all facility level staff on the NMC system. Your CDC district, sub-district focal person should monitor timely the submission of Category 1 and Category 2 NMCs and the case investigation forms. They should then assist in sending reminders to facilities, treating the facilities, treating clinicians, your IPC nurses, general practitioners to submit the NMC form online or via paper if the sub-district does not allow for online reporting, as well as the completed case investigation forms, reminders to please complete and to send it on to the focal persons from the Environmental Health Practitioner Office. The District CDC, NMC Surveillance and Environmental Health Focal Persons, together with members of the District Outbreak Response Team, must ensure the appropriate public health measures and response, investigation and interventions are implemented and coordinated. Ensure there's upward reporting of your cases to the province as well as to the NMC national system. The notification process for health facility-based reporting from hospitals, clinics, or private practices. Your agricultural or stock remedy poisoning is reported through a written or electronic notification within 7 days of clinical or lab diagnosis, but preferably as soon as possible following a diagnosis. Capture the NMC case details onto the NMC mobile or the web app that you have to go to new case if your lab report is not already in the system. If your lab report is already in the system, you go to cases and then to edit case in order that you access the different subheadings to update and save that information. Upon completion of your data capture, save all the data and the notification will automatically be sent to all relevant focal persons at your health establishment, sub-district, district, province, and national. Paper-based notification is used only where there are scarce resources, and that will be applicable for the Western Cape. Paper-based is only used with scarce resources in the Western Cape. Send the NMC case notification form to your NMC surveillance report at nict.ac.za or for NMC hotline on 0726213805, and the forms can be sent either via SMS, WhatsApp or email. Send a copy also to your focal persons at sub-district and district levels, and also, your details must be given on the cover page of the NMC booklet. Those are for people who are using the paper-based booklets. That is what you have to do, is to provide the different focal persons names, surnames, and their contact details on the booklet for all clinicians who are in resourced poor areas where they don't have access to the app, where they can readily see who the focal persons are at the different levels. Notify your suspected cases on the app. The official will notify the local authority, the Department of Health, your province, and also national. The laboratory for public and private must inform the health facility, IPC, practitioner, facility manager, CDC at the provincial level, district level, as well as sub-district level of any confirmed lab cases. Roles and responsibilities, just a update again. Your step 1 will be preliminary assessment, step 2 inspection, look out for hazard evaluation and your risk assessment. Step 3, information and risk communication to all the different focal persons, all the healthcare workers involved, so that remedy action can be taken by all involved, or environmental health practitioner or SAPs. And then management plans must be in place for step 4. And then step 5 will be all key interventions need to be carried out. Your contact persons for the Department of Health in the Western Cape. This is the list of contact persons, and also not to forget your Poisons Control Center. The number for the Poisons Control Center is 0800 22 21 222. your contact center for poisons information, again, your centers in the Western Cape. So for more information and assistance with any possible poison cases, the following persons can be contacted on 0861 555 There is a Red Cross Children's Hospital Poison Information Center, and the number is 0216585308. At Tygerberg, they have also a Poison Information Center, and the contact number is 0219389334. Bilharzia, schistosomiasis, the epidemiology. So this is a parasitic fluke infection acquired by skin exposure to surface water inhabited by infected intermediate host snails. Two species of schistosome produce urogenital and intestinal infections respectively, with both shared and organ-specific clinical features. It's caused by parasitic worms and considered as one of the neglected tropical diseases. Who should notify? Every nurse, every doctor receiving the laboratory report, or if you know that there are cases to investigate the contacts or people living close to or have had exposure to that same areas, water, stagnant water, rivers or canals. Laboratory also has to make the diagnosis from the specimen that was sent from the facility. A suspected case definition is any person with a compatible clinical feature of acute infection. That may be fever, hepatosplenomegaly, urticaria, diarrhea, etc., or intermediate infection that can be hematuria, cervicitis, etc., or late infection that may be hydronephrosis, portal hypertension, etc., and history of exposure in an endemic area. A probable case definition, a person with compatible clinical features and a history of exposure in an endemic area, plus a single positive serological or antigen test and or hematuria and or raised eosinophil count. Confirmed case definition is a schistosome eggs reported in the urine or the feces or histopathology in biopsy samples, or a more than or equal to 4-fold rise in titer of serological tests over 2 weeks or repeatedly positive antigen test. Just to have a look at your life cycle of the Seichere infectious form of the parasite. So in number 1, the mature flukes in your blood vessels of the intestine will be a male and a female. So note that is one fluke. So it contains both male and female reproductive organs. Then on 2, your blood flukes reproduce sexually in human hosts. Fertilized eggs then exit the host in the feces. And then 3, eggs develop in the water into ciliated larvae, and the larvae will infect the snails. Then 4, you note that asexual reproduction within the snail results in another type of a motile larva. Then the larvae penetrate skin and blood vessels of the human being when they enter that canal, that river, or stagnant water. Okay, and then it just goes around again to start from 1. So now they lay that the host, once he's infected, maybe the human being, he defecates into that water, and it goes around again where the flukes will go into the intestines. Your blood flukes reproduce again go into the shells of the snails, and once they again reproduce the motile larva, it goes into the water and waiting for a host to burrow into the skin and into the bloodstream, and it can take up to 2 years for that larva to actually go and lay eggs and cause damage to your organs. And that's usually when the patient comes to the health facility with blood in the urine or pain, and when the sample gets sent off, that's when the eggs will be present for schistosomiasis or bilharzia. Your lab test samples and your case investigation form, so the diagnosis by microscopic identification of the parasite eggs in stools or urine. Serological tests are useful to diagnose early or late. Test sensitivities and specificities vary depending on the antigen preparation used and how the test is performed. Your rapid antigen tests that indicate active infection are available in some laboratories only. Healthcare workers should screen your asymptomatic people who may have been exposed during travel and who may benefit from treatment. Complete a case investigation form and send a copy to your environmental health practitioner for follow-up. So the environmental health practitioner will then go and do some water testing and try to rectify that area so that reinfections do not occur. How is it treated? So the treatment in South Africa is praziquantel effective. This is effective against all species of schisto. It's much less active against immature worms as compared to the adult worms. So single dose treatment early in infection is only 60% to 90% effective. Retreatment is a requirement, just in case the person have been infected early on. Not effective as a pre or a post-exposure prophylaxis though. Treat your brain and spinal cord involvement cases early and also potentially devastating sequelae. Adjunctive steroid treatment, dexamethasone, is generally recommended if there's brain involvement. Prevention, avoid wading, swimming, or other contact with fresh water in disease endemic areas. Untreated piped water coming directly from freshwater sources may contain the sequelae. Adequate filtering with fine mesh filters, boiling bathing water, or allowing water to stand for more than or equal to 24 hours before use can eliminate the risk of the infection. Swimming in adequately chlorinated swimming pools is virtually always safe, even in disease endemic countries. Vigorous towel drying after accidental exposure to water that may be infected with these snails and the larvae has been suggested as a way to remove the sequelae before they can penetrate the skin, but this may only prevent some infections and should not be relied upon. Topical applications of insect repellents such as DEET can block the penetrating sequelae, but the effect depends on the repellent formulation. So that's also kind of an iffy option. May be short-lived and cannot reliably prevent your infection. Resources will be, again, your NICD homepage. You can go and contact our Center for Emerging Zoonotic and Parasitic Diseases. If there's any urgent medical or clinical related queries, you can call the healthcare professionals only hotline on 0800212552. Congenital syphilis, the epidemiology, a condition affecting an infant or child who is under 2 years whose mother had untreated or inadequately treated syphilis. Early congenital syphilis may present anytime in infancy or early childhood under the age of 2 years. An infected infant may be asymptomatic at birth and develop signs 4 to 8 weeks after birth. So if a mother has been incorrectly treated, not with Bicil and other antibiotics, to note that it does not cross over placentally. So if that baby is having a titer that is positive for congenital syphilis, consider that child to have congenital syphilis. But if the mother was treated fully and with the correct bicillin, then if your child has no symptoms, irrespective whether the blood result is positive, that baby is usually not considered to have congenital syphilis. You can contact your NMC coordinator to have that removed from the system. All children should be followed up for at least 1 year who are infected. Who should notify is all nurses and doctors receiving the laboratory result for congenital syphilis, a suspected, probable, or confirmed case definition. So it's any case meeting the following criteria: a live birth or fetal death at more than 20 weeks of gestation, or who weigh more than 500 grams. That's inclusive of the stillbirths born to a woman with a positive syphilis serology and without adequate syphilis treatment. Adequate maternal treatment is defined as at least one injection dose of 2.4 million units of intramuscular penicillin or bicillin at least 30 days prior to delivery. So from antenatal perspectives, clinicians can make a change by ensuring if your mother was screened antenatally and found to have syphilis, to do another screening at least 30 days prior to the delivery, so that if she is positive again, adequate treatment is delivered to her, and that will ensure that the child does not have congenital syphilis. Or the next is or a live birth, stillbirth, or a child aged under the 2-year period born to a woman with positive syphilis serology or with unknown serostatus and with lab evidence of syphilis infection, regardless of the timing or adequacy of your maternal treatment. The following constitutes acceptable lab evidence. So demonstration by dark field microscopy or fluorescent antibody detection of your treponema pallidum in the umbilical cord, placenta, nasal discharge or skin lesion material, or autopsy material of a neonate or stillborn infant. So the PCR positive on umbilical cord, placenta, nasal discharge or skin lesion material or autopsy material of a neonate or stillborn infant. Analysis of CSF is reactive for venereal disease research or elevated CSF cell count or protein. Infant with a reactive RPR serology titer fourfold or more than that of the mother. An infant with a reactive treponemal serology titer less than fourfold more than that of the mother, but that remains reactive for more than or equal to 6 months after delivery. Infants with a reactive RPR or VDRL of any titer and any of the clinical signs listed below, born to a mother with a positive or unknown serology, independent of treatment, and then also any stillborn infant with a reactive maternal test should be considered a congenital syphilis case, that is syphilitic at birth when it is stillborn. And or a live birth, stillbirth, or child aged under the age of 2 years, born to a woman with positive syphilis serology or with unknown serostatus and with radiographic clinical evidence of syphilis infection, regardless of the timing or adequacy of maternal treatment. Suspected cases, probable and confirmed case definitions. Acceptable radiological evidence refers to long bone radiographs suggestive of congenital syphilis, and or a live birth, stillbirth, or a child aged under 2 years born to a woman with positive syphilis serology or with unknown serostatus and with clinical evidence of syphilis infection, regardless of the timing or adequacy of maternal treatment. Acceptable clinical evidence in settings where a non-RPR titer is not available, An infant born to a mother with reactive or unknown serology independent of treatment and whose 6-month examination demonstrates any of the early clinical signs as listed below. Early clinical signs that may be present in an infant with congenital syphilis include non-immune hydrops, hepatosplenomegaly, rhinitis, and skin rash, pseudo-paralysis of an extremity or failure to thrive or achieve developmental milestones. They're thriving or they failing to achieve that developmental milestones. An older infant or child may develop additional signs or symptoms such as frontal bossing, notched and picked teeth with Hutchinson's teeth, clouding of the cornea, blindness, bone pain, decreased hearing or deafness, joint swelling, sebaceous, and scarring of the skin around the mouth, genitals, and the anus. Case investigation form, please note that it's only available on the web-based platform of NMC app. So it is combined within your NMC form. So if you are completing the notification on a web computer, a plus will then be that your case investigation form is also automatically completed. But if you are completing it on a mobile-based platform of the app, then you have to still go to the web-based computer to complete that section, or you print out the case investigation form after completing your notification on the mobile device. You have to print out the case investigation form, complete it, and then email or scan it to all your focal persons in your province. Haemophilus influenza type B, your epidemiology, also called HIP. It causes pneumonia, septicemia, meningitis, epiglottitis, septic arthritis, cellulitis, otitis media, and purulent pericarditis, as well as less common invasive infections such as endocarditis, osteomyelitis, and peritonitis. Infections are clinically indistinguishable from infections caused by other bacteria. The spread is by droplet or direct contact with respiratory tract secretions. Asymptomatic carriage may also occur. A probable and confirmed case definition cannot be notified as a clinical suspected case. So note that HIP cannot be notified as a clinically suspected case. Invasive disease such as bacteremia, meningitis, epiglottitis, cellulitis, septic arthritis, pneumonia, empyema, pericarditis, or osteomyelitis, where the public health physician, in consultation with the physician and microbiologist, considers that HIP disease is the most likely diagnosis. So the isolation of Haemophilus influenza type B from a normally sterile site specimen, for example, blood, cerebrospinal fluid, pericardial or synovial fluid, or a positive gram stain and latex result, or a positive PCR result will be your confirmed diagnosis. Hepatitis A, the epidemiology, it's an enteric virus transmitted via the fecal-oral route of any kinds of food or water. Outbreaks of hepatitis A may occur following point source contamination of food or water, or transmission from person to person within households or institutions. Who should notify your lab, as well as your nurse or doctor receiving that lab report? A clinical suspected case not to be notified clinically as it mimics any other cause of acute infectious hepatitis. So lab report. Suspect your presence with an acute onset of fever, headache, malaise, anorexia, nausea, vomiting, diarrhea, abdominal pain, or dark urine, along with jaundice or elevated total bilirubin or raised serum ALT levels in the absence of a more likely diagnosis. A confirmed case will be a lab confirmed case of hepatitis A, diagnosed in a person with compatible symptoms and the presence of a hepatitis A specific IgM antibody test. Yeah. Your case investigation form must be completed for all hepatitis A cases, and please send that to your environmental health practitioner for follow-up. Vaccine preventable. However, this vaccine is not part of your EPI program, like hepatitis B will be. It may be purchased in the private sector or obtained in the public sector for high-risk persons, for example, persons undergoing chemotherapy or transplants, or persons with inherited disorders of the immune system. Hepatitis B, it's a viral infection of the liver, presents with acute or chronic symptoms. Your modes of transmission include perinatal, bloodborne, for example, in the healthcare setting or sharing of needles, and also sexual. It's usually preventable by vaccination. There is a vaccine which can be administered as part of the expanded program for immunization at 6, 10, and 14 weeks, followed by a booster dose at 18 months. Your clinical or suspected cases, the case definition, it's acute hepatitis B, may not be notified clinically again. So as it also mimics as the other hepatitis, any other causes of acute infectious hepatitis may be suspected, and the patient will present with an acute onset of fever, headache, malaise, anorexia, nausea, vomiting, diarrhea, abdominal pain or dark urine, along with jaundice or elevated total bilirubin or raised ALT level. In the absence of a more likely diagnosis, your diagnosis must be confirmed with a lab test. Chronic hepatitis B may be asymptomatic, or it may present with a range of symptoms from mild right upper quadrant tenderness to symptoms of cirrhosis or hepatocellular carcinoma. A confirmed case will be acute hepatitis B, anti-hepatitis B IgM positive or anti-hepatitis B IgM positive, and hepatitis B surface antigen positive. Chronic hepatitis B surface antigen positive for 6 months or longer. Refer to a specialist guidelines for additional diagnostic parameters. The pattern of positive antigen and antibody combinations may evolve over time. Therefore, the diagnosis of chronic hepatitis B may be complex. Just some notes and other resources. Congenital hepatitis B may occur if an infant is born to a mother with acute or chronic hepatitis B. Congenital hepatitis B is preventable by administration of a birth dose of hepatitis B vaccine. However, the South African EPI does not include a birth dose of hepatitis B vaccine. This vaccine was introduced into the National EPI program in 1995. So persons born before the 1995 period are at higher risk usually for acute and chronic hepatitis B infection. Hepatitis C and E are not that common. Hepatitis C is a viral infection of the liver. Transmission of hepatitis C includes perinatal, bloodborne, or in a healthcare setting, or sharing of needles, and sexual. Hepatitis E virus is an enteric virus transmitted mainly via the fecal-oral route. Hepatitis E may be associated with outbreaks of acute illness. Severe disease may occur in pregnant women in their third trimester, and the mortality rate is usually high, at least 25%. Legionellosis, the epidemiology. So it's a disease caused by bacteria from the genus Legionella, commonly presents with a spectrum of illnesses ranging from asymptomatic to severe pneumonia. That's the Legionnaires disease, often requiring hospitalization. It may also be acquired from inhalation of contaminated aerosols, so that can be from any kind of evaporating system, air conditioners not serviced within a 6-month period, or from any shower heads in communal showers, in gyms, dormitories, people sharing. If that area can be scrubbed, the head of the shower, with pot chick water, it can also prevent the Legionella bacteria from growing. It can also be obtained or acquired from boilers, which are filthy and not being serviced regularly. Your suspected, probable, and confirmed case definition. So suspected is any person with a clinical radiological evidence of pneumonia where the public health physician, in consultation with a physician and microbiologist, considers that Legionnaires' disease as the most likely diagnosis. Your probable will be any person with a clinical or radiological evidence of pneumonia with Legionella pneumonia, non-serogroup, or other Legionella species, specific antibody response, fourfold or greater rise in specific serum antibody titer, confirmed in any person with clinical or radiological evidence of pneumonia and at least one of the following. So isolation of Legionella species from a respiratory specimen or any normally sterile site, detection of Legionella pneumophili, serogroup 1 antigen in urine, detection of Legionella species nucleic acid in a clinical specimen, Legionella pneumophila, serogroup 1, specific antibody response that will be fourfold or greater rise in specific serum antibody titer. Lab sample and your case investigation form. So any respiratory sample, for example, sputum, nasopharyngeal swab, you can use to send it off to the lab and ensure that you keep it cold up until it reaches the lab. Urine in acute phase or blood, but the gold standard remains your culture from respiratory samples. Complete your case investigation form, send a copy to your environmental health practitioner for environmental follow-up. Leprosy or Hansen's disease, the causes and the case definition. The prevalence in South Africa is less than 1 per 10,000 of the population. We have a leprosy mission in South Africa, and it estimates that about 3,000 people are infected with leprosy in SA. It's caused by the microorganism Mycobacterium leprae. Suspected cases will be a case of leprosy as defined in any person having one or more of the following: hypopigmented or reddish skin lesions with definitive loss of sensation, damage to the peripheral nerve as demonstrated by loss of sensation and weakness or morbidity of the muscles of the hands, feet, or the face, and for confirmed cases, it would be a positive skin smear for acid-fast bacilli or positive biopsy, but where lab tests cannot be conducted, a diagnosis is often established from the patient's clinical signs and symptoms. Note that there is no probable case definition. Your treatment, there is a multi-drug resistant treatment, so a multi-drug treatment. If the patient has 5 lesions, so the patient needs to know their skin and look out, or the clinician needs to look at the patient's skin, the entire body skin, look out for the either lighter than the skin, darker than the skin, raised or flat lesions. If there are 5 lesions, they treated for 6 months with rifampicin, dapsone, and clofazimine. If there are more than 5 lesions, the patient is treated for a 12 to 18-month period with the same rifampicin, dapsone, or clofazimine. The national policy is aimed at early diagnosis and treatment, prevent disability, finding and treating your infected contacts by encouraging your relatives of known patients to report for screening for possible leprosy, and also caring for those who are disabled by leprosy. Your awareness can be increased by having health talks in your waiting areas or putting up posters which are visibly showing what the lesions look like and where people can go to access more information and what they need to do in order to be investigated. Soil transmitted helminths, that's worms. The epidemiology, it's caused by the species including Ascaris lumbricoides, hookworms, or your Ancylostoma, DOD nail, and Nicata americanus, and Trichiura, that is your soil-transmitted helminths infections, may also be asymptomatic even if there's heavy infections, and it will be associated with a considerable morbid state, including abdominal pain, diarrhea and anemia, as well as impaired cognitive and physical development in children. Infections focus on the morbidity or control through the use of mass drug administration of your anti-worm treatments or drugs, and to target your preschool and school-age children, as well as other at-risk groups. So at-risk groups would be any adults even who are having lots of animals, and working with a lot of soil, and also if there's a chance of not washing your vegetables and fruits properly. Who should notify any healthcare provider, nurse or doctor, or if the lab detects it from a sample? Now, note that it's only confirmed by a lab. So only if you have a patient who is reporting or the caregiver is reporting, you give a sample for a container, a stool container for stool collection or live worm collection. Keep it cold up until it asks the patient to cover it and keep it in the fridge up until it reaches the healthcare facility. Healthcare facility to keep it cold up until it reaches the lab. Only if the lab isolates the 4 names we've mentioned in the previous slide, then it will be considered positive. Case definition. There's no case definition of a suspected case. Probable is also not applicable, only confirmed by the lab for the real-time PCR detection of the different names, and only if they find those to be positive for those names, then it can be considered a soil-transmitted infection. Sample and treatment, stool or live worms, as I said before, keep it cold. Deworming should happen 6 monthly or at least once a year. 6 monthly deworming for children, and at least once a year for at-risk adults. Tetanus epidemiology, it's caused by bacterium Clostridium tetani. In neonates or adults, tetanus follows contamination of a wound or umbilical stump with a bacterium in a susceptible person, preventable by immunization with tetanus toxoid as part of the EPI program. Tetanus toxoid is given at 6, 10, or 14 weeks with boosters at 18 months, 6 years, and 12 years. Your neonatal tetanus is targeted for elimination. Maternal immunization with tetanus toxoid may prevent neonatal tetanus. A suspected case will be any person more than 28 days of age with acute onset of at least one of the following. So trismus, that's lockjaw, sustained spasm of the facial muscle or generalized muscle spasms. A confirmed case will be a neonatal tetanus patient, so an infant with normal feeding and crying in the first 2 days of life who subsequently loses that, and between 3 and 21 days of life, he will then develop muscle rigidity and spasms. Children and adults of, so that can be any person over the age of 28 days of age with acute onset of at least one of the following. That's the lockjaw, your sustained spasm of the facial muscle, or generalized muscle spasms, where the diagnosis has been confirmed by a physician or any other trained clinician, nurse, or doctor. What to do? You do your notification on the app, or paper-based if the app is not available in your province. Complete your case investigation form, obtain an EPID number and write that on your case investigation form, as well as any specimen form. Your EHP, environmental health practitioner, should do the follow-up. For example, for boys going to initiation schools, if the surgical procedures have not been followed and cow dung has maybe been put onto the circumcised penis area, then there is a chance that tetanus may develop with necrotizing of the penis, and any area where the environmental health practitioner can make a difference. That's when they need to go and do the follow-up of the neonatal cases, or if a herbalist or herbal remedies which were not sterilely used were used. That's also when the EHP can go and investigate and remedy, correct the whatever is wrong. Majority of your category 2 NMCs are lab confirmed. Please note that. So your NMC app, mobile or web-based, must be used. You go to cases on your NMC app on the homepage, click on your filter, your latest cases, then lab only. Then edit your case, complete all clinical data entry and save. Thank you very much for the Western Cape. People in the different districts can contact me on 0647424005 with NMC related queries or app queries. Otherwise, if another province, then contact your notifiable medical conditions coordinator for that province. If that person is not available or I'm not available, you can contact the notifiable medical conditions hotline on 0726213805. Thank you so much.